Okay. All right.
I've opened my what you call it? Wait, hold on. A slideshow. Okay. Hi. I'm Lynn, as you can hear from my accent. I'm also originally from South Africa, but I came on Aliyah when I was 18. So all my professional studying and professional work, all that is based in Israel, except for a couple of years, for 5 years when I lived in California, but primarily trained and professionally have all my experience from working in Israel. I am an occupational therapist. I've worked all my professional life in psychiatry, in mental health. I know the system very, very well. I've worked in hospitals. I worked at Shalvata, which is a very, very good psychiatric hospital for many years. I've worked in a program called Kfar Izun, which is a program for dual diagnosis, also one of the best programs in Israel. I was part of a team that we set up a day treatment clinic in Netanya. And I've worked in what's known as Sal Shikum, which is the psychiatric rehabilitation programs, also for another 13 years. So that's why I actually offered my services to Susan, because I just know the system backwards. You can wake me up in the middle of the night and say to me, "Well, hey, this person needs this, that, the other. How do I do it?" And then after a few years ago, I kind of was a bit burnt out. I said, Yalla, I'm going to take early retirement, stopped working, um, and then found myself back working in this program for a company called Sharan, which is a medical care program that does services at home. And I've done a number of services. Then I was in the field. I did some management things. And today, amongst other things, I said to the owners of the company, I want to be in what's known as, in Hebrew, we call it Kishrei Kihila, in touch with the public, because people do not know what exists in Israel and what are their rights. It's very confusing. Programs develop, programs of opening, Kupot provide this, Misrad Abriyut provide that. People don't know. So for the company, I've taken on and something of just explaining. I'm available to people to know what exists, because we all know people can have different needs. And today, mental health is not just or hospital or clinic. There are lots and lots and lots of things in between. But to know how to handle it, what are your rights, how to get it, is a whole nother story. So that's why I offered to Susan to kind of be on the other side of the WhatsApp. Susan would say this, that, the other, and I would try and help. Okay. Um, I see everybody's got their cameras off. Um, I kind of like when I speak to interact as much as possible. So if you've got questions, want to say something, want me to clarify, I'll put it this way. I don't know how to speak English or Hebrew. They kind of get mixed up all the time. So just feel free to interrupt me, or if I've said something in Hebrew and that's not something that you understand, just ask. And I just wanted to take ad advantage of my knowledge, which, as I say, from working 30 years in the field in Israel, is pretty much built in. It's just part of my being for you to know, because sometimes it happens that the services that you can give in your clinic are just not enough for what the person needs. And then what do we do? And that's exactly why I want to be here. And maybe you can like start thinking of like maybe patients or questions. And okay, because my aim is to help you just understand what is available in Israel. I'll start off asking a question. Do you all know that there's home psychiatric hospitalization in Israel?
Yeah, I do, but I don't know about everybody else.
No, I don't.
If you could put your cameras on, those who haven't, it would be easier, I think, for Lynn to talk to you, if that's okay.
Yeah, because it's kind of more, I'm more like
It's,
more to be interactive than like a lecture.
Thank you
more
very
So
much.
if I
energy.
could be honest, I'm on my treadmill, but if it's be better, I can get off it. I just thought I'd walk and pay attention.
Yeah, no, just kind of, I don't know, everybody make their own decision, but it's
It's
easier for me to talk
nicer,
when it's
yeah, it's much
a
nicer.
chat. Yeah, I've just made the PowerPoint just to make sure I don't forget anything. Okay, so this company I work for is a private company that provides the services to the Kupot. Okay, everybody understands what the Kupot are? It's the health services. Um, it's a company that for over 20 years has been given health services in the home. Mm. The owner of the company, Dr. Eve, 22 years ago said, we don't need to have the little old lady sitting in the passageway of the hospital, or you're very sick and you need to be in hospital, or go home and the medical team will treat you at home. And today there are closer to 700 healthcare team members who work for the company, and we give treatment not only in mental health, because mental health home treatment was only started 4.5 years ago, but the company specializes in treatment at home. And that means basically a hospital at home, which is a whole different operation than having a hospital that with all like on the same floor with the nurses looking. So it's actually a family company, and that's what we're seeing here today. The CEO is Eve's oldest son, and we all work with them. I just want to tell you, even though I'm going to put the rest of the discussion just on the mental health, I want you to know about other treatments that are available in Israel at home. One is what they've written here, home hospitalization, which is acute home hospitalization. That is, instead of being in an internal ward, a person can have the treatment at home. That means somebody who needs to have IV antibiotics, they can have it at home. A doctor and a nurse come every day. Somebody who needs to have IV, anything IV basically. Certain things cannot be given at home, but a lot of things can be at home. So it's important to know for yourselves, for your patients, for your neighbors, for the little old lady downstairs. A lot of times when even when you go to the ER and they say, uh-oh, we need you to be hospitalized, you can ask, do I need to be hospitalized or can this be home hospitalization? Because it is covered 100% by the Kupot. I'll just give a tiny example. My mom wasn't well. She went to the ER. They put her, she needed to be hospitalized. After 2 days, she was starting getting better. We saw she was on the correct antibiotic. I said, can we continue at home? And they said, with pleasure. And it was all paid for by the Kupa, instead of her being in hospital with IV antibiotic for 5 days. After 2 days, she went home and continued. And we all know the benefits of being at home. We also know that there's some things that can only be done in hospitals. So I'm not anywhere along this, am I against hospitals? But I'm saying hospitals for when we need to be hospitalized. Hospice at home, I think everybody understands today that that's something that exists. There is also blood tests at home. We all know, oh my God, I have to get up, make an appointment, not make an appointment, stand in line. All the support, if you have a referral from your family doctor, you can order somebody to come and take your blood tests at home, at work, wherever you've chosen. Everything else is free except the blood tests. Each Coupa demands that you pay a little bit of money. But we sometimes hear, especially with psychiatric patients who need to have blood levels once a month or things like that, and the person doesn't get together to go. I don't want to wake up. I can't wake up. Just know it exists. Okay, and then there are other programs that we do. But I do want you just to all know that today Israel is, as well as the whole world, is very, very, very developed as what you can do at home. Okay, but you actually have to know about it to ask, and that's what I'm here to tell you. We work with lots of different companies. All the boats who have Israeli flags, for example, the medical treatment is given through Sharan. Okay, the gas, what you call it, asadot, the gas in the middle of the sea there, all the medical treatment. Okay, because we basically know how to do treatment, not in an office and not in the hospital. That is our speciality. Okay, what I'm speaking to you now about, as we all here, therapists, and we all volunteer for Tikva, different, everybody in the different way, is about the mental health programs. Okay. Our model here, this young-looking gentleman, is our main psychiatrist. He looks like a kid. Okay, he's one of these young, smart young men. He's actually an Ole Hadash himself. He came from Russia, and he is in charge of the whole program for the medical management. We have lots of psychiatrists. We have something like 17 psychiatrists who work with us. And we have a huge team of about 80 people in the mental health team. We give services from the north to the south. Okay. Sometimes, if it's some very remote place, we might have difficulty having a full team go in for the home visits, but then sometimes some of the visits will be online. But theoretically, we cover the whole country. Now, what's important to know is we started doing it with a pilot program to check that it could work 4.5 years ago. Together with the health ministry, we wrote the standards and built a way that the Kupot Cholim get money for the home hospitalization from the health ministry. It always takes a long time for programs to start working, especially with the big Kupot, Clalit and Maccabi, which give services to millions of people. It takes a long time for new programs to get into the system. But for the smaller Kupot, which are more Chedet and Leumit, we've been doing it now, as I say, for over 4 years. As soon as Clalit, about 1.5 years ago, said they're going to start giving it, it became a game changer, because they're the biggest healthcare provider, and suddenly it's something that can be spoken about. Susan spoke about the balancing houses, which, for example, I remember when they started, it was also oh my God, what's a strange way of treating people. Today, they've been running for, I don't know, for 10, 15 years, and people know that it's an option. So there are basically two options for alternative for hospitalization in Israel. One of them is the Batim Ma'aznim, the balancing houses, and the other is the home hospitalization. The Kupot pay for both of them. There is no, if the Kupa approves it, it doesn't cost anything for the patient. That's important to know. Okay. It was started because, as we all know, people who suffer from more severe mental health problems, often there's a bit of the revolving door phenomena. People tend to go often to hospital when they're not feeling well, because a lot of people who especially have some more type of chronic problem, they've learned that the hospitals are a place for them to be able to get help. And you kind of see it with a certain age of patients. Like younger people tend to not go to the hospital because they've already learned that there are other options. The older population who've been hospitalized a couple of times have already learned it's part of their way of being in the world. Oh, I'm feeling bad. I'll go to the psychiatric ER. And the reason that we wanted that this program came up was to promote recovery. We know that when a person's in his house, it's not the nurse giving him the medicine, saying kind of come to the nurse station, open your mouth, swallow. Let me check that you've swallowed. But it's a person who has to start taking responsibility on his own recovery. To remember, these are the times he's supposed to take the medicine, what time he goes to bed, because there's no lights out, like in a hospital. Somebody's able to start, taking responsibility on feeling better and what needs to be done to feel better. We also found that there's absolute unbelievable improvement of adherence to treatment, because often after hospitalization, when everything's been done by the staff, from the food put on your table to when you can be in your room and you can be out of your room and you need to swallow your medicine. When a person gets home, they often just stop because they haven't learned to take responsibility for the process. So there's totally enhanced cooperation and adherence to treatment. And the one thing I want to say, basically, for everybody who knows hospitals, home hospitalization is the equivalent of what is known as an open ward. An open ward is somebody who wants treatment and they're not dangerous to themselves or to the other. I've written here that you can also reduce this duration of stay in a closed ward, because sometimes it happens if somebody's feeling like really bad and they put in a closed ward, and for a few days or a few weeks, they need a lot of support and help. As soon as they're no longer dangerous to themselves, then they can transfer to home hospitalization. Your mic is off, Judith. We can see you talking from your mouth.
Oh no, I'm just like being amazed. But I
Oh,
was
yeah.
curious if all of these services, if children are also eligible.
No, it's from the age of 18.
Ah,
From the age of 18.
but in the US, you have a couple days in the hospital, you go home to nothing.
Yeah, I know. Okay, so it's important to know, because sometimes if somebody's been like in a really bad way and they're put in the hospital and they have to be there in a closed ward, and then after a few days, weeks, whatever, everything's improved, and then they no longer have like forced hospitalization, and the staff says to them, I'd rather you stay because you're not fully stabilized. We want to help you just like do the next, do the next few miles, kilometers, whatever. And the person says, no, I don't want to be here anymore. I'm so sick of the hospital. And instead of discharging them to nothing, because as soon as somebody wants to be discharged, if they're not in like forced hospitalization, they can go home. It's important for the staff to also know that they can offer them another option. This care is provided by a multidisciplinary team. Everybody gets a psychiatrist, a nurse, a social worker, and psychotherapy if they're able to. And depending on the needs, sometimes a dietitian, sometimes an OT, there are different things based on the different group report. I'm not going to go into all the details. Staff normally sees the patient for 7 times a week. Okay. Again, it depends on the kupa, depends on lots of things, but basically 7 times a week is the number of visits that a person will get in the first few weeks. And some of the meetings are not what we call not by the staff coming into the house, but rather by Zoom. Okay. For example, the psychiatrist will see the patient once a frontal visit and once by Zoom in a week. What's the name of our psychiatrist who's sitting here with us?
Deborah.
Deborah. As Deborah, I'm sure, can say with me, we know that psychiatric medicines take a while until they have an effect. So there's not really much option of the psychiatrist, going into the house every week, because the psychiatrist is available to the patient. As soon as the person is in home hospitalization, the team is available for him. So if he's taking the medicine and he's not feeling great or he's got questions, he can speak with the psychiatrist. The nurse is actually the most important staff member. The nurse sees the patient 3 times a week. And a lot of people say to me, why do you need a nurse in psychiatry? The psychiatric nurse is actually the most important person. It helps a lot with adherence to medication, because we know that a lot of people won't take medication because they're scared of the side effects. They've read on the blurb, sometimes it'll say for schizophrenia, but the person's been suggested to take some antipsychotic because his thoughts are like really, really bad, and just to help him feel a little bit better. And the person says, but I'm not schizophrenic. You're not schizophrenic, but he needs somebody to be there with him within the process to explain. Somebody will say, oh, I'm itchy. It's because of the medicine. So the nurse is really, really there to help with understanding what the medicines can do, what are the side effects. And if there are a side effect, he's seen the patient 3 times a week. He's going to like say, wow, we're going to treat it straight away. The social worker helps with all the rights of the patients. Okay, if it's a person who they meet who needs bituach lumi, how do we call bituach lumi in Hebrew? In English?
English. B'tuach Leumi is like social service. No, it's not
Yeah.
really.
Yes. It's not social services, it's
Insurance.
sorry.
They're the pension B'tuach Leumi, and they
Yeah,
help
no, but they also give like
disabled
money for people who have got
benefits.
health disability. So if somebody needs to put in a claim for disability to be Tuach our social worker can help them. If somebody needs to put in a claim for the rehabilitation basket, our social workers help him. So it's very important. And again, if the person can benefit from psychotherapy, they can also have psychotherapy. Um, I've written here a home environment that is conducive to the treatment process. Exactly what the house is like, the home, it differs a lot from lots of people. I'll give an example of a man who we had who was living with his father, and his father was like shouting at him every day, "Get up, go to work, go to work." And his brother was a druggie. It was not an environment that was good for the person. It was not somewhere that he was going to be able to get better. But we've also we helped him get to a balancing house. We've also had people who their home is like sort of what we'd call a shed. You know, they're like sort of sleeping on a mattress in the shed, but that's their home. So a conducive home environment depends a lot. As I said, excuse me, there has to be an absence of risk to self or others, okay, because we are not there all the time. Now, I want to describe this one other issue of a primary caregiver. The country will not provide home hospitalization to somebody who is totally alone. I've had lots of time people say to me, oh, he lives by himself, he fights with everyone, he's not in contact with any of his family, no one, because we are not there 24/7. We have to have a partner. We have to have some type of partner. The partner doesn't have to live with him 24/7. It can be the the neighbor, the kid, the friend, the brother that they're fighting with. It doesn't really matter, okay? But we need somebody who will be in contact with us, will tell us the person's not feeling good. If we phone and want to make an appointment and the person doesn't answer, we'll phone the primary caregiver. We'll say, hey, what's going on? He's not answering. And then sometimes, they'll come back to us and say, oh, he's just sleeping or his phone's off or things like that. We also don't give the medications. We give a prescription. So the person has to be able to fill the prescription. And we know when you're feeling really bad, just to think to walk to the chemist, to the pharmacy is like a major issue. And also the house has to be livable. Somebody will make sure that the garbage is emptied, that there's food in the fridge. Okay. Um, so don't like ask me about somebody who lives totally, totally alone and with no one. Those type of people, maybe it is better for them to go to a hospital where the medicines will be provided, the food will be provided, somebody will check on them. Okay. Um, the diagnoses are the same diagnoses that we see in psychiatric hospitals. Because as I say, it's the same type of person. It's just somebody who's not dangerous to themselves and somebody who has an environment that is conducive for some type of support and for taking care of them. What I wanted to also say, when somebody's hospitalized, we know that like they'll maybe call the family in, for like what they call Pychiatric, to meet with them, to give them some type of training. Here, because we're going into the house, we are seeing the family at all times. So there is continual work with the family. Sometimes you can go into a house. I'll give an example again of somebody who I treated. Beautiful apartment, one of these like, new buildings, all done nicely. The man was alone all day. Where's your wife? On paper, there's a wife, the younger daughter still living at home. They couldn't bear him. They couldn't bear him. They didn't want to take care of him. As they woke up, they left the house and they came back just to go to sleep. The house was always clean, tidy, but this man was as alone as can be. Where's your wife? Oh, she's at work. Oh, she's at our married daughter. There was like no one that was actually giving him support. So you learn a lot by going into the house. Because as I said, this was a story on paper, perfect. On paper, the father and the brother who were living with the patient, also perfect. But sometimes we see that it's not. And it's really important. I've been in a house of a father of a little kid who'd been in hospital and then came home. The little 2-year-old always wanted to sit with his father on the couch, which was perfect for me because it was important that the father was being a father. Of course, what we spoke about was suitable for the kid to be around. And the kid there was with his dad, instead of his dad disappearing on him again. How does it work? Okay. We have to have a psychiatric referral. Now you're going to say to me, oh my God, it's impossible to get appointments with psychiatrists. So sometimes a person get a referral from the family doctor. Okay. Now, as I say, each kupa, each area is slightly different. So what I suggest, like through Susan, you can always just send me a WhatsApp. Hey, this person lives in here, this kupa, Last saw the psychiatrist, what can we do? And then I'll tell you because every kupa, every area is slightly different. So we have to have a referral. Okay. And it's a medical model. And so it has to be by an MD. As non-medical doctors, when we see the problem, we can often speak with the family doctor and say the person's, the mental health, the non-functioning, and our recommendation, and the family doctor will write a recommendation. So don't feel that you've got no part in it. I work a lot with all the social workers from the rehab basket. I work a lot with them because I just help them work out how they can try and get a referral. We get the referral. Normally, the referral can be sent to me. Then we speak with the patient to get permission from him to send it to the kupa. We send it to the kupa, what's a bakar of a kupa? Somebody who's doing all the person who's in charge of seeing if the person is eligible or not. Okay, it's normally a doctor or a nurse. Each kupa is slightly different. They check. If they think that the person is eligible for home hospitalization, they'll give permission. And then as soon as we get the permission, and you've all heard about the famous Tofish Fastre, which is that the kupa will pay for it. As soon as we do that, you don't need, so all you have to help the patient get is a referral. All the rest we will do. And then within 48 hours, we send a psychiatrist from our team to do an intake. At the intake, the psychiatrist assesses the patient and checks that the patient is actually suitable for home hospitalization. Again, that is going to cooperate, because again, this is all something that can only be done with cooperation with the team. The person can be concerned, express, like I'm concerned about taking the medicine, what side effects, what will I do? We're there to speak with them, but somebody has to agree. They have to actually agree to open the door when we arrive. So it's something that we have to do together, and that the person again is not dangerous to himself or to somebody else. Okay. Then after the referral, we send after the intake, we send the summary of the intake to the kupa, and we say, yes, this person's suitable, and we ask the kupa for permission, meaning we tell them what the treatment plan will be and what we're going to do. And every 2 weeks, we have to send a summary of what we've done and what the treatment plan for the next 2 weeks will be to the kupa. And because it's a lot of money, think of them, they're sending a whole team to the house. So the kupa's got to be responsible what they do with the money. So they check, and we are responsible for every 2 weeks to send them again a summary and to say what our plan is. Normally, now I think Judith spoke about like 2-3 days hospitalizations in the States. Israel, again, hospitalizations are also short. Sometimes they can be a week, sometimes they can be a few days, sometimes they can be 35 days. The average number of days of hospitalization is something about 35 days. Again, being in a balancing house is also just a little bit over a month. For home hospitalization, the average is about 45 days. So we're talking about something which is short-term, intensive, multidisciplinary, that's coming in to help the patient. As I said, we also do the beginning of all the rehabilitation process that's needed. All the patients and their caregivers are given the phone number of the nurse. Our nurses are required or demanded to give their personal phone number so that the patient is never alone. And we have a 24/7 call center with our staff. Now they're not therapeutic staff, they're staff that we've trained. And if somebody phones and says, I'm feeling bad, I need to speak to the psychiatrist, they'll connect them up. If somebody phones at 3 in the morning and says, we have this quite often, I can't remember when the social worker's coming tomorrow. Okay, they're not going to phone the social worker to check at 3 in the morning, but we also know sometimes 3 in the morning, you wake up, you've got all the different anxiety. It's like a good excuse to speak to somebody on the other side of the phone. What time's the social worker coming? So our call center staff, we've trained them to know when it's just something that they can say to the patient, we'll get back to you tomorrow. Or if it's something more clinical, then there's always somebody that they will be in touch with. We will not leave a patient who's called us without some type of intervention. We're not against hospitals at all. We sometimes refer to the ER, but we do not want a patient to go to the ER without us help, like suggesting. So that means somebody's, again, I'm going on this 3 a.m. in the middle of the night, think that they're having a heart attack or whatever, call us, speak to us, and our doctors all will write a referral and suggest that you go to the hospital, or they'll speak with you, calm you down, and say, I'll be over in the morning. So it's very, very important to know. I kind of call our 24/7 call center, I sort of call it the nurse's station, because we know sometimes in the hospital in the middle of the night when you've woken up and you don't know what to do with yourself, you go to the nurse's station and you sometimes just ask for a glass of water because you want just somebody to give you some type of, personal interaction. So, and that is something that I really like, and we like train the call center staff. And our whole thing is when we discharge the patient, we have to discharge them with appointments in the community. They have to have a psychiatric appointment, and if we recommend that they're going to have psychotherapy or a social worker to help finish with all the different things that they need with the national insurance or the rehab basket, we'll connect them up. We're not allowed to just release somebody with nothing. We have to have appointments for them. Okay. Now, the only kupa that my company does not work with is Maccabi. Okay, because the different companies that do the services. Okay, so if you have a patient from Maccabi, speak to the the if even the main secretary in the Maccabi clinic and say to them, who's the provider? Okay. Because today all the kupot do it. And we need to make sure that the people who need it get the services. Because sometimes it's new, they don't know, the doctors haven't read the emails that they've gotten explaining. Okay, so our job is mamash to help the person. And what I've discovered, the person who knows the best what's happening in the kupot for the main services is not only is more even more than the family doctor, is the main secretary. The main secretary gets all the emails and she reads them and she knows. Okay, so take advantage of that to say, hey, what are the options? How do I help my patient get home hospitalization? Okay, because often we need to help people, get what they are eligible for. This is just showing the diagnoses. Over 46% of our patients suffer from depression, 12% schizophrenia. Okay. Now, what I want to say, we treat people who have, some type of mental health illness that they've had for many years. We treat people, who've got a diagnosis and are just going through an acute phase. We also treat people who it's the first time, who they do not have a diagnosis. They have a number of symptoms, okay? Anxiety, crying, not eating, screaming at the family. It doesn't matter, but you're not sure quite, you don't necessarily have a diagnosis yet. It's something new, it's something that's happened, and the person's not coping, okay? So that's why you can see it's written, where's it written? Acute and transient psychotic disorders. We don't know exactly what's going on, but the person needs help. So take that into account. Now, with the chaos of what's been going on in the country, we've met people who, were totally normal, functioning people. They had incredible stress and kind of just lost it, everybody in their own way. They hopefully, it'll be something that will be transient, then they won't end up having to have all the treatments. I see you, Susan. 1 minute, fine. They won't necessarily have to have, all the big services. They just need short-term, intensive, multidisciplinary team. So remember that. That's good for us to all know. It's not just the person who says, oh, I've suffered from, depression my whole life, or have a schizophrenic diagnosis. Yeah, Susan, I'm with you.
Okay, regarding that, we have somebody who, or I have somebody that I speak to when he's having a psychotic attack. And when he's having a psychotic attack, he's really completely off the rails. And my initial reaction is to call the ambulance and get him to hospital because he needs to be cared for. He's not safe to be on his own. Now, he's not suicidal in those moments. He's definitely not suicidal. But at the same time, he's not fit to be, he needs to be seen. So what would happen with a patient like him, because he hates going to the hospital? It's such a balagan to get him there. And more often than not, the ambulance will turn up and say, after they've broken his door down or something, oh, we're not taking you tonight. You'll have to just stay at home and wait, or something like that. Many a time they've refused to take him. So what would happen with somebody like that who really needs medical care in that moment, who is on medication for anxiety and psychosis, but sometimes the anxiety gets so bad that he's just so overwhelmed that it's just, it can't be left. So how would your services kick?
We are not instead of an ER. We are not instead of an ER. We are instead of somebody who, um, I always tell, like, the social workers, the psychologists, if you see somebody who's slowly, like, going downhill, and if we don't catch it this week,
Yeah,
and next week, there's going to be no option but to go to the ER.
yeah.
Okay. we need you to catch it before the person needs the ER. The process takes a few days, sometimes even a week.
So
Okay.
if I
So,
was to speak to this person, okay, let's say when he's rational, and explain that this service is there, if this is what, if the track I'm going down is correct, to
yeah.
prepare the situation if he needs that. Um,
No,
no,
no, because the referral is has to be like
immediate.
up-to-date referral.
Okay, okay,
An
no
up-to-date
problem.
referral. For somebody like that, I would probably speak with a psychiatrist, make sure that you've got SOS treatment that can be used, train the person what to do to be aware when he needs to take his SOS treatment. That type of person, has he got the rehab basket? Because that would be their job to help him, you
Sorry,
know. Does he have like the staff from the rehabilitation basket?
I don't know. I know he's on. I think he's got some shall she come, but I'm not sure how much.
Yeah, because that would sort of be their job. And that type of person, if it was my patient, I don't know if it would suit, I would like kind of say, like, what do what do you do when you're going to lose it? Have you got extra, I don't know what, medication that you can take? What has your psychiatrist said? But no, that's not an option.
Oh,
Somebody who's like just lost it, that's the ER.
okay. And what languages is this available in?
Um, Look, basically, there's definitely Russian.
Right.
Okay. There's definitely Arabic.
Okay.
There's English. There's English. Not everybody will speak like perfect English, but it'd be enough. I wouldn't like per se say that, let's have like psychotherapy,
No, no, but
in
for the
spoken English.
psychiatrist and these services.
Yeah,
Okay.
yeah.
Okay.
But basically, I mean, all the professionals know to speak English. It's not going to be like, you know,
Mhm.
necessarily speaking to you in English, but all medical staff knows English. And as we've got a lot of Russian speaking
I
staff.
can imagine. Yeah.
Okay.
Wonderful.
But the person is saying, oh, well, somebody will say, but if it is speak English, I speak English. It's not going to work. Those type of people are, if they're not going to be flexible. Okay, we know what living in a country where the main language is not your mother tongue, you have to have flexibility.
Yeah, that's one of the biggest problems my people have. It's finding services that are available in their own language, and the hardest thing to find is a psychiatrist. That's the nightmare. And Clalit particularly, to get therapy or any of those services in English is just impossible. Very, very hard. Clalit is one of those, for some reason, their language skills in English is very poor. That's the one I get the most complaints about.
Mm. I don't know. I think one of the things today, I mean, it's off topic, is we have to learn to communicate with Google Translate. I'm talking about like a psychiatrist or something when it's maybe something, you know what I mean, that you're not going to see every week. You're going to see now and again. I think that's one of the skills we have to also learn is that English. We might all be sitting here and saying that we come from English speaking countries, but English is only one of the languages in the world.
Absolutely.
And I think being flexible is part
Mhm.
of part of how we actually cope with our mental health. Because if we too, not prepared to like think out of the box,
Yeah.
life's going to be very, very difficult.
The only
Um,
problem being, and I'm sure you've come across this problem many times, Lynn, is when, no matter what language you speak, when you are in a crisis, your own language is the only one that you can really focus on, because
that's one.
brain pattern just won't allow you to focus on another language while you're in a crisis. It's just not.
Absolutely. And then that's why sometimes in my therapeutic work, I always say one needs to like build like a regimen what we're going to do when there's a crisis.
Yeah.
You know, maybe I'll have it all written down what normally happens to me when I'm in a crisis. So it's written and being translated, and I can give it. I mean, obviously, the person that I'm going to be having as who can be my emergency translator. those types of things. I think that's one of the important things that we have to
Good idea. Yeah.
that we have to be able to do. Okay. Um, as I say, I call myself like a rehab specialist, a psychiatric rehab specialist, and I work a lot on like, recovery and illness management, and those are all part of the skills that I think we need to help clients. I know you're sitting here probably more, all of you as like more dynamic therapists, which I'm not,
No, but
you know.
I think that actually is a very good tool to tell people. Like, for argument's sake, I work with a lady who has very severe bipolar swings, and when she has them, oh my gosh, she's off the scale. But her biggest fear is that if she goes to the hospital, no one's going to understand her. But actually, what you've just suggested about putting down a crisis plan in her own language and having it translated so she can go to the hospital and say, this is what's happening to me, is actually a really good idea. It's a really good idea.
Mhm, mhm. Yeah, pre-crisis plan is excellent. Yeah.
Really clever idea.
Yeah.
I think it's part of
Um,
her care package. I think it's fabulous.
yeah, no, because as I said, somebody who's like calls me, hey, Lennon, we need a psychiatrist now. Even if the person wants to pray privately, I'm not going to we're not going to get a psychiatrist, who's like sitting doing nothing to be there within the next 10 minutes. We can make an appointment for the next.
But there's also, you can ring the Revachad, can't you, out of hours for the emergency on-call psychiatrist if there's a real problem. That's available in
Yes,
every.
yes, yes. But sometimes, the psychiatrist who comes and spends an hour speaking with you, thinking with you, listening to you, helping you to get your medications right. It's today. There's no, there is the emergency room for crises, and like I don't mind giving people my phone number, but I can always like say, but I'm not an ER. Like, don't try calling me, Lynn. I need your help now.
Yeah,
Because I try and be available to explain, to help people connect, because I honestly believe that people need to know, don't feel well, want the treatment at home, but it has to be, yeah, no, I've been dealing with somebody who apparently has been driving the nurse crazy, the nurse from the Kupa crazy, because and they might just be too in a bad way to be able to wait for the whole process.
yeah.
It sounds like they should have maybe had the referral given about 2 weeks ago before they like hit rock bottom, because it's not only depends on us, it depends, like as I said, we do the intake, then we send it to the Kupa, and then only then do we get permission for the full hospitalization, because originally we're just going to get the permission for the intake.
Yeah,
So
it's a process that they have to.
yeah, so that is exactly why that's exactly why I like speaking to therapists and the people who see the staff members from the Sal Shikum, because people who see the patients all the time, like once a week, they can see when a person's starting to like lose it, and they can like come on in to say, hey, let's like build the options. And one of the options is let's get a referral for home hospitalization, but it has to be up to date. So you know, because it has to be
Yeah.
telling about the process now.
Okay.
Um, the age, what I said to you is the main age of people coming is from age 21 to 40, which makes sense. Those are people who are not used to going to hospitals. Today, there's much less stigma than there used to be. And somebody will say, I'm in a bad way, I want help. So, come to my house and help me. The older population used to, I don't feel well, I go to
Mhm,
hospital.
mhm.
Okay. Now, we treat very, very old people also. Okay. Which we know very old people to go to hospital is like really not a good idea. They like totally like lose all, you know, orientation. So remember that. Okay, that we can treat all ages. We've had a little old lady who was getting, nutrition through her, you know, wasn't eating, but was getting nutrition through her stomach, and she was sure that her family was starving her. And we came in and helped calm her down, checked that she was getting all the food, that she wasn't being starved, We did all, because we do all the blood tests and everything for our patients. We do blood tests, we do injections, we do everything, and try to train her caregiver how to help her. So just take it into account that they're all types of patients. I'm not just talking about the young man who's got the 2-year-old kid and wants to get back to work as much as quickly as possible. So just take that into account. And it's not necessarily the type of person that you're doing online psychotherapy with, but it's a person who's in a bad way and needs a team to come inside and, into their house and to help them.
Hmm.
As you can guess, mainly women like getting the treatment at home. Okay. Okay. Now I just want to tell you there's another program. Now this program, I'll take 2 minutes and just tell you, is only applicable for the two small kupot, Lumit and Mujedet. Okay. Now what happens, just to explain how the mental health system here works, that the small kupot have less staff and they're always looking for options. And a smaller infrastructure, so it's easier for them to implement the options. We have a program that is called, it's kind of a program, and eventually all the Kupot will have it, but it's to save people having to go to the emergency room. If a family, somebody, it's for the person who refuses to go to the doctor. He's in his house, there's chaos. He's crying, he's screaming, he's not coming out of his room, all the chaos that we know that can happen. And the family doesn't know what to do. If they go to the kupa, to the clinic, and they say, my son, my husband, whatever, my father, and then you'd say the staff, as of today or as of yesterday, the staff of the clinic would say, oh my God, we need to get together, me, the doctor, the nurse, they never go alone, to go into the house to assess what's happening. Today, they are able to ask for the crisis team. We call it a mental health crisis team, and the Kupa sends us. And as I say, learning to give treatment in the house is a skill that we
Hmm.
have,
Hmm.
and that we have. Our staff is trained in it, and that our staff goes in with a referral from the Kupa, goes in, does an assessment. We can go up to 3 times, and we check. It's exactly what's written here. What's going on with the patient? Okay. And we do a risk assessment and we make recommendations, what is suggested. It's amazing. As I say, it's only the small kupot. So it's always kind of people forget because, oh my God, no, he's in the wrong kupa. But it's to save the person who is just causing chaos and refuses to go to the doctor, but will agree for somebody to come and check them at home. And I'm really excited about this because we all know that the chaos is at home. The person who's prepared to go to the hospital is already on the way to feeling better, to being taken care of. Okay, so Susan, this is will be very confusing for you because you're going to have to remember it's only the two small kupot. The ishpuz bayit, the home hospitalization, is all the kupot. Right. Okay. But what happens, and this is with the company that I work for, and it's what I like about the company, we're always developing more programs. And so they always start off small and not, not readily available to everyone, but eventually they become available. So this is an amazing team. Amazing because if anybody's ever tried to get the medical team from your kupa to come to visit in your house when there's a crisis, it takes weeks. It takes weeks because they also won't go in alone. They're scared. They'll always make sure that they're two people. And we know how to do it. Our staff knows how to do it. And that's what we do. Again, if the patient refuses to open the door, then there's nothing we can do. But we find that most people will agree at this stage. Home hospitalization we must ask the patient, can we come in? Here, sometimes it will be enough if the family member says, I'm here, I'll open the door and I'll talk to him and help him say, agree to speak with you. Again, in Israel, there exists like, the forced hospitalization when somebody comes to take you from your house. We're not talking about that. That's given by the head psychiatrist of the country, not through the Kupot, through the Ministry of Health. We're not there. We're not there. We're here working with a person who agrees to be worked with. Okay, so this is an exciting program because it's really, really helping the chaos in the house. Now there's what we do for all our patients, we send them a survey to see what they feel about the treatment. Everything's out of 5 here. And as you can see, the nurse always gets the highest score because the nurse is the person who is there for the patient. We all know that you need one person to be out there for you. And it tends to be the nurse because they see the patient the most. Okay? They see the patient 3 times a week. But everybody's got like good scores, and that's very important to us. Okay. Yeah, just warm words the patients have said, the surface truly saves lives, makes accessible to more people who are in deep distress, can't even consider hospitalization in a psychiatric hospital. It's a perfect solution that they come to your house. Some people obviously don't say amazing things. Some people kind of say, why didn't they stay longer? Why isn't she blonde? Those types of things. He came late. He said I was going to be there at 6 and he came at 6:30. We can't help everyone, but we really, really try to be there. And we send to both the patient and the caregiver the survey, and anybody who's got bad results, we check out what happened, what went wrong. Sometimes it's just something that we learn that a team member's not, functioning well. Sometimes we learn that the patient is just incredibly critical, but we do take every survey seriously. Okay, now there's another program again that it's hard. Susan, remember this, but you can't just overall refer because it's a new program. We did an 18-month pilot program for people who suffer from severe SMI, severe mental illness, but I'm not just talking about functional schizophrenia. I'm talking about people who spending their lives going to the hospital or just visiting the ER all the time, or long hospitalizations. And we built a program based on ACT, assertive community treatment, based on an ACT it's called FACT, FA, flexible assertive community treatment. It's a program that runs in Holland. We got funding from Social Finance Israel, and we did this pilot. And our main thing was so people wouldn't go to hospital and to help people get more connected with the services in the community. And we had our team which included the case manager, multidisciplinary team. They also had our psychiatrists available to them on Zoom, and our team had our psychiatrists available to them as well. Though, as the main psychiatrist would say, they're people who basically had every medication in the world. It wasn't only the medication, it was very much the whole support system. And what was most important for us, and what's the Kupot, the country, likes about it, it reduces the number of hospitalization days, you can see, by 72%. An unbelievable saving for the Kupot. Okay, unbelievable saving. So now today, we're working with the health ministry, with the Kupot, to see how we can do this program. Some of the Kupot and some of the areas are letting us start to get these very severe, what we call the chronic, I don't know, it's the name that the Kupot have given it, patients, and to try and help them. So, Susan, if you've got someone, speak to me, because, as I said, it depends which area, which Kupa. It's not a program that's just out there running like home hospitalization. It's again another program that is wonderful. I mean, you can see, but it was because it was done by the SFI, social finance. There's research all along. So you can see, and it's going to the research is going to continue for another 4 years to actually see the long-term effects for the patients. And these types of programs I find very exciting because we're not just, as I say, home hospitalization. Today I can tell you we know what we're doing. We've done it for 4.5 years. We know how to do it. We know who yes, we know who no, and that these other programs are new and we're starting to do it. Okay. Um,
Incredible.
sorry.
It's incredible. This is really, and truthfully, it's incredible.
Yeah, absolutely. Okay. Just so that you know, we do, we've started giving online psychotherapy for some of the kupot. Okay. It doesn't cost anything for the patient. It's online. And today we have therapists who have Hebrew, Arabic, and Russian. Okay. Again, I know that that's what you guys do, but if you want to check what's available through the Coupa and how to do a referral, again, Susan, you feel free to send me a WhatsApp.
Yeah.
Okay. And I will try and help you. Again, it's not everywhere. Today it's only available in 2 areas of the country. Slowly the Kupot, because what happened with all the crisis that's happened in Israel, the Kupot are trying their best to provide more services. So for example, we were not a provider to the Kupot. Today we are a provider. And I mean, you guys do an unbelievable, amazing work, but just so that you know,
Well,
maybe.
this is possibly useful for those people who we struggle with. Um, sometimes we do struggle to find therapists that are willing to work with some clients. So this could fill that niche.
Yeah, but I see, like, we don't per se have English therapists. I can maybe check if we do,
No,
if
but
it's
we do
even.
get people requesting Hebrew, and we definitely get people requesting Russian. Um,
Yeah,
sometimes we struggle because the number of therapists that we have that speak that language is decreased. So, I can see it's 15 sessions, which sometimes is not enough, but sometimes it's enough to get them a bit more stable.
but sometimes it's 30. So yeah,
Ah,
okay, it can be 30. But just be in contact with me, Susan,
I
and
will. I'll
but
keep
also as I say, we're not for Clalit, we're providing it just in 2 areas of the country. For Mochedet, we're supposed to provide. Just be in contact with me. I'm not going to drive you bonkers,
no. I'll speak to you because what I'd like you to do, if you could provide me with the slides that you've shown, the presentation that you've shown. I mean, I know I've recorded it, but I could
Yeah,
together
yeah,
with
I can send it to you.
yeah,
Okay.
put it
Okay.
together in a
All
book.
right. And then we've got a program, but unfortunately it's only private. We haven't found funding through the country yet. It's for youngsters, those kids who like kind of don't want to go out of the bedroom and the
Yeah.
families don't know what to do. So we do have a program for that. And unfortunately, though, we haven't been able to find funding. So today this program is only private. It's expensive. Anybody who's going to pay for private therapy, it's expensive. But our speciality is to help those people who are like kind of, you know, closed in their room with a computer. Mom, leave me alone. I'm fine. You guys aren't. And this is not based on a medical model because it can even start just working with the family. They're not against having psychiatrists come in if need to be, but it's not somebody that the kid has to be out there and say, I want treatment. They can come sit in the lounge, speak with the family, try and like, get the kid to come, play the guitar with the kid, play the computer game with the kid to just connect up with him. Okay, which is an amazing program, but unfortunately, as I say, no one's taken it within the public field. Okay.
It's a shame that
Um,
it's happening more and more
yeah.
these days that children are with teenagers are withdrawing and not talking.
Yeah, so that's and our biggest problem is unfortunately that it's still only private. Okay, all our treatments we also do privately, you know, if the Coupa doesn't pay, a lot of people phone and want the psychiatrist to come because they don't want to wait 2 months for a psychiatrist to the Coupa. They'd rather pay and have a psychiatrist who'll come through us. So, and we'll sell our services privately, even though we try and sell everything, to the Coupot.
And when you say privately, what would it be privately to visit a psychiatrist?
Psychiatrist who comes to the house, 1,800 shekels.
A visit.
Yeah, yeah. Okay. But I see Judith pulling her face, but there are people who have money in Israel, There are people,
Charge a lot more than that for private psychiatric care as well here.
yeah. There are people who have money and there are people who don't. As I say, we wish we could get everything through the services provided by the country, but sometimes we have to open up our credit cards. Okay.
Are nurse practitioners approved to prescribe in Israel?
Yeah, it's just starting. It's unbelievable.
Oh.
It's just starting, and yeah, they just finished the first course now. They're all like the head nurses of the different coupot, and it'll be interesting to see exactly how it will be developed. But yes, the company I work for today just said to me, Lynn, because give us the name of a nurse practitioner, a man that I've met in one of the hospitals who was like training this program. We want to start like getting him to like help us see what we do. So you cutting edge question. Yeah.
I mean, we've all got such bad faith in the mental health sector, to be honest with you, in this country. I mean, people literally don't know how to access services. They've got no idea what's going on. And especially if you're an alert, and even if you're not an alert, I think people don't have any idea. And people go to the ER and they're badly treated. They wait 4, 5, 6, 7, 8, 9, 10 hours to be sent home with nothing sometimes. And then they end up back there the following day because they're still in crisis. So this is really heartwarming to hear, to be honest with you. And it's been really educational, really, really informative. Yeah, I really.
Yeah, that is why I said to you, I want to like share with you because
I think what I'd like to do is maybe see if we can get this to a broader spectrum. So maybe we'll organise it for another day and I'll advertise it outside of Tikva as well. So that means that we'll get a wider spectrum of people joining us. Maybe we can fix the date because I think it's really important that people know about this.
absolutely, absolutely. That's why I suggested, because these new programs are like, okay, I'm going to remember it's this Coupa, that Coupa, but at least the home hospitalization is now all the Coupot.
Except for Maccabi, who you have to ask them who they're servicing you. Right?
Yeah, but anyhow, you're going to have a referral through the Coupa. Okay, so it's not a biggie. You have to learn to say you have to know that it exists, and you have to say, I want a referral and I wanted to get to the provider. That's it.
Okay.
Okay. That's it. Not everybody knows Lynn and has my WhatsApp number for the one company that I work with. Okay.
No.
But it doesn't matter because theoretically you don't need me.
No, it's true.
Okay. Theoretically you don't need me.
We always need
you. Have to, but you have to just know that it exists.
Yeah. Yeah.
And it can all be done through the family doctor. Okay. Sometimes the family doctors, they still say, oh, that's not body, that's whatever, nefesh, they won't deal with it. But we can't help all of that. But theoretically today, a family doctor can also give a referral.
Okay, brilliant. Thank you.
Okay. But Susan, I can just help, because I know people who I work with them, but it's all the Coupot. I waited to tell you till I came to you, because to just tell you something for...
No, it's exciting. It's very exciting. It's another tool that we can give to our clients.
Yeah. And it's for those people that what you do, your support, which is wonderful and unbelievable, is just not suitable because it's not enough.
No, sometimes we can't offer enough. You're 100% right. And no psychologist or psychotherapist can sometimes offer enough. Clients need sometimes more intervention. And I'm very, very aware of that.
Yeah,
Very aware of it. But obviously, if somebody is in major crisis, then the first thing they need to do is go to the ER and then get the referral that way through their family doctor afterwards.
absolutely.
Yeah,
Absolutely.
I mean, trying to avoid people going into a locked unit is, or a Barbanel, if we can, is much better.
Yeah.
Really,
Yeah.
really.
Okay. Sometimes the truth of the matter is, Susan, I kind of know like all the main staff of all the hospitals. So
Oh, okay, that's a useful conversation to have then.
maybe, you know what I mean? You just spoke about the Barbanel, like, you know, I know the head social worker there, the doctor in charge of the ER there. So I don't know how much I can always help, but
Yeah,
you
but you
know,
might regret that comment.
I don't know how much I'll be able to help, but I'm just saying because of me being because of the position that I developed for myself in this company, I'm just connected to people, and because I was also worked in this field for 30 years.